Hello and good day, ma'am. So, I am Dorika Kong, the reporters of the Crohn disease under the inflammatory bowel disease. So, the objectives is at the end of the lessons, the students are expected to define inflammatory bowel disease, uh, Crohn disease, and B is know its pathophysiology, and C. Learn the clinical manifestations. And D. Classify different assessment and diagnosis findings. Know the complications of Crohn's disease. And the last one is assess student learning about the topic like Crohn's disease, risk factors, immune response in Crohn's disease, pathophysiology, clinical manifestations, assessment and diagnostic finding, and also the complications of the Crohn's disease. So, first, we're going to tackle the inflammatory bowel disease, which is IBD. So, when we say inflammatory bowel disease is a group of chronic disease. So, Crohn's disease, example, regional enteritis and ulcerative colitis that result in inflammations or ulcerations or both of the bowel. So, both disorders have striking similarities but also several differences. So, when we say the Crohn's disease, regional enteritis, Crohn's disease is characterized by periods of remissions and exacerbations. It is a subacute and chronic inflammations of the GI tract, which is gastrointestinal tract, wall that extends through all layers, like transmural lesions. Although it is characteristic, histopathologic changes can occur anywhere in the gastrointestinal tract. It most commonly occurs in the distal ileum and the ascending colon. Approximately 35% of patients have only ileal involvement. Ileitis, 45% of patients have disease ileum and colon, colitis, and 20% of patients have only colon involvement, granulomatous colitis. So, when we say Crohn's disease is a chronic condition characterized by inflammations in the gastrointestinal tract, which is also known as digestive tract. Since Crohn's disease is a chronic illness, it is persistent and will be present throughout a patient's life. However, patients and traditional can work together to manage the symptoms of this disease. The gastrointestinal tract include the mouth, esophagus, stomach, small intestine, large intestine, and anal region. So, Crohn's disease can affect any part of the GI tract, but most commonly affected portions of the gastrointestinal tract is the last part of the small intestine, which is called ileum. The first portions of the colon, cecum, which is referred to as the large intestine. So when we say the ileum helps to further digest food. coming from the stomach and other parts of the intestine. It absorbs nutrients, vitamins, minerals, carbohydrates, fats, proteins, and water from the food. Um, so they can be used by the body. So current thinking is the Crohn disease is the genetic disease caused by abnormal regulations of immune system. So the G tract, gastrointestinal tract, is frequently confronted with bacteria from our diet and environment. So they are factors of Crohn. So many factors can contribute to a person's risk having a Crohn disease, but most categories is genetic predispositions, environmental factors, dysregulated immune response. So here, the risk factors: the genetic predispositions, environmental factors, dysregulated immune response. So which causes inflammations? So when we say the environmental factors that may contribute to Crohn disease include infectious, smoking, antibiotics, and anti-inflammatory drugs known as NSAIDs. And one way that the body can protect against the potential bacterial tract is within inflammations. So the immune response in Crohn's disease, inflammations is a ulcer. So ulcers appear within the gastrointestinal tract, and immune system work to combat the bacteria and viruses in the same way as with the out on the cycles on the skin. However, the difference in the immune system is not able to turn itself off after it's gotten rid of the bacteria or virus. So the answer is remain until they are treated with medicine or surgery. This chronic inflammation is caused by symptoms of Crohn's disease. So, the symptoms of Crohn's disease vary. Symptoms vary depending on locations and severity of inflammations. This means that every patient with Crohn's disease experiences the disease differently. So most patients with Crohn's disease have abdominal pain and diarrhea. Other symptoms related to gastrointestinal tract include abdominal tenderness, lost appetite, weight loss, fever, fatigue, rectal bleeding, anal skin tags, and ulcers. In the children, Crohn's disease may result stunted growth. Means stunted is the impaired growth and development that children experience from poor nutrition, repeated infections, and inadequate psychosocial stimulations, and also a failure to thrive. Means when their weight or rate of weight gain is significantly below that of other children of similar age and sex, even if the gastrointestinal symptoms are not present. In addition to symptoms involving the gastrointestinal tract, Crohn's disease can affect other parts of the body. Symptoms outside of the gastrointestinal tract include joint pain, liver inflammations, osteoporosis, skin problem, eye problem, mouth ulcers, and anemia. So, Crohn patients can lead normal life through appropriate management strategies. So, next is we're going to the pathophysiology. So, the inflammatory process in Crohn's disease begins with the creep inflammations and abscesses, which develop into small focal ulcers. These initial lesions then deepen into longitudinal and transverse ulcers separated by edematous patches, creating a characteristic cobblestone appearance to the affected bowel, like fistula, fissures, and abscesses form as the inflammations extend into the peritoneum. The pathophysiology of Crohn's disease begin with the craft inflammations and abscesses, which progress to tiny focal optoid ulcers. Crohn's disease can be found in both the small and large intestine. However, it seems to be most common in the terminal of the ileum and the beginning of the colon. Next is we're going to clinical manifestations. So the clinical manifestations, the the onset of symptoms is usually insidious in Crohn's disease, with prominent right lower quadrant abdominal pain and diarrhea, unrelieved by defecations, scar tissues, and the formations of granulomas interfere with the ability of the intestine to transport product of appear intestinal digestions through the constrictive lumen, resulting in the crampy abdominal pain. So the clinical manifestation of Crohn's disease, diarrhea, fever, fatigue, abdominal pain, and cramping, blood in your stool, mouth sores, reduced appetite also, and weight loss, pain or drainage near or around the anus due to inflammations from a tunnel into the skin, fistula. And then next is assessment and diagnostic finding. So assessment and diagnostic finding, the traditional conclusive diagnostic test for Crohn's disease was a varium study of the upper gastrointestinal tract that show a string sign on an X-ray image of the terminal ileum, indicating the constructions of a segment of intestine. However, this study has fallen out of favor with the introductions of improved CT scan and MRI techniques that can more accurately assess bowel and pelvic disease. CT scan can highlight bowel wall thickening and mesenteric edema as well as obstructions, abscesses, and fistula. So, according to my research, there's no single diagnostic test for Crohn's disease. If you show sign or symptoms of the conditions, your doctor may use a variety of tests to check for it. For example, they may order blood tests, stool tests, imaging tests, colonoscopic sigmoidoscopy, or tissue biopsies. Colonoscopy with endoscopy, capsule endoscopy, computed tomography, entography, and small bowel follow through are often used to diagnose Crohn's disease. So the complications of Crohn's disease include intestinal obstructions or stricture formation, perennial disease, fluid and electrolyte imbalances, malnutrition from malabsorption, and fistula and abscesses formations. So, obstructions, the most common complications of Crohn's disease, may arise from swelling and the formations of scar tissue. The result is thickening of the bowel wall and narrow intestinal passage. So that's all for my report of Crohn's disease. Thank you.
Hi ma'am, I'm Junhani Nurhaida. So for today, my tackle is about ulcerative colitis. So when we say ulcerative colitis, RUC, this is causes irritations and ulcer in the large intestines, which also called the colon. It belongs to a group of conditions called inflammatory bowel disease or IBD. It often causes diarrhea with blood, cramping, and urgency. Ulcerative colitis is a long-term condition where the colon and rectums are become inflamed. So the same symptoms of ulcerative colitis is diarrhea, abdominal pain and cramping, rectal pain, rectal bleeding passing small amount of blood in stool, urgency to defecate, inability to defecate despite urgency, and wet loss. Ulcerative colitis treatment usually involves either drugs, therapy, or surgery. So that's all. Thank you.
Assalamualaikum ma'am, I am Sena Kali. So my topic for today is about appendicitis. So appendicitis is the most common surgical emergency of the abdomen. So appendicitis happen when your appendix become inflamed, can be acute or chronic. So acute appendicitis. Acute appendicitis is a severe and sudden case of appendicitis. The symptoms tend to develop quickly over the course of 1 to 2 days. So it's required immediately medical treatment. If left untreated, it can cause your appendix to rupture. This can be a serious and even fatal complication. So acute appendicitis is more common than chronic appendicitis. So the appendix is a small vermiform worm-like appendage about 8 to 10 cm or centimeter, then 3 to 4 inches long, that is attached to the cesium just below the ileocecal valves. So pathophysiology, the appendix become inflamed and edematous as a result of becoming kinked or occluded by the facillate hardened mass of stool. The lymphoid hyperplasmia, secondary to the inflammation or infection, or rarely foreign bodies, fruit seeds, or tumors. So the inflammatory process increased intraluminal pressure, causing edema and obstruction of the orifice. Once obstructed, the appendix becomes ischemic, bacteria overgrowth occurs, and eventually gangrene and perforation occurs. So the causes is many things can potentially block your appendix, including a build-up of the hardened stool, enlarged lymphoid follicles, intestinal worm, traumatic injuries, and tumors. So when your appendix become blocked, so bacteria can multiply inside it. So it can lead to the formation of the pus and swelling, which can cause the painful pressure in your abdomen. So next is clinical manifestation. So vague perumbilical pain, visceral pain that is dull or poorly localized with anoxemia progress to the right lower quadrant, perennial pain that is sharp, decreased, and well localized. The nausea is approximately 50% of the patient with the appendicitis A lower grade fever may be present local tenderness. The local tenderness may be elicited at McBurney point when the pressure is applied. Next is beyond tenderness. Beyond tenderness producing or intensification of the pain when pressure is released. The next is reversing sign. So reversing sign may be elicited by palpating the left lower quadrant. This paradoxically cause pain with the to be felt in the right lower quadrant. Then, if the appendix have ruptured, the pain becomes constant with the peritonitis. So abdominal distension. Abdominal distension develop as a result of the paralytic ileus in the patient condition worst. The next is constipation or loss of appetite. And then laxative or cathartic should not given when the person have a fever, nausea, and so when the appendix is inflamed, tenderness can be noted in the right lower quadrant at McBurney point, which is between the umbilicus in the anterior superior iliac spine. Reversing sign is pain felt in the right lower quadrant after the left lower quadrant have been palpated. So next is assessment and diagnostic findings. So diagnosis is based on the result of the complete history and physical examination and on laboratory findings and imaging studies. So first is CBC. CBC demonstrate an elevated white blood cells and count with an elevation of the neutrophils. So C-reactive protein level are typically elevated. Next is imaging test. So may also recommended on abdominal X-ray and abdominal ultrasounds, computerized tomography. Next is CT scan may reveal a right lower quadrant density or localized distension of the bowels. So enlargement of the appendix by at least 6 mm or 6 mm is suggestive of appendicitis. So next is complication. So complication of the appendix include wound infection, dehiscence, bowel obstruction, abdominal pelvic abscess, and rarely death. So the most common complication of the appendicitis are gangrene or perforation of the appendix, which can lead to the peritonitis. So next is a gerontologic consideration. So acute appendicitis does not occur frequently in the elder population. So classic signs and symptoms are altered and may very gentle pain may be absent or minimal. So symptoms may be vague, suggestion, bowel obstruction, or other process. So fever and leukocytosis may be not be present. As a result, diagnosis and prompt treatment may be delayed. And then next is medical management. So surgery is indicated to the appendicitis is diagnosed. So to correct or prevent fluid and electrolyte imbalance and dehydration, antibiotics and IV fluid are administered until surgery is performed. So analgesic can be administered after the diagnosis is made. So morphine sulfate 10 mg ml. Next is antibiotics, ciprofloxacin to 25 mg to 500 mg. Levofloxacin 500 mg, metronidazole 500 mg, 100 ml and 400 mg tablet. Next is a nursing management. So the goal including relieving pain, preventing fluid volume deficit, reducing anxiety, eliminating infection from the potential or actual disruption of the GI tract, maintaining skin integrity, and attaining optimal nutrition. So the nurse prepare for the patient for the surgery, which include an intravenous infusion to replace fluid lost and promote the adequate renal function, and antibiotic therapy to prevent infection.
So next, assessment and diagnostic findings. So the white blood cells count in elevated and may demonstrate a relative increase in the immature neutrophils, which is the bands, consistent with bacterial infection. Hemoglobin and hematocrit levels may be low if blood loss has occurred. Serum electrolytes studies may reveal altered levels of potassium, sodium, and chloride. An abdominal X-ray may show air and fluid levels, well as distended bowel loops. Then the abdominal ultrasound may reveal abscesses, which is localized collections of the purulent material surrounded by inflamed tissues. And the fluid collections and ultrasound-guided aspiration may assist in easier placement of drains. So next, the medical management. So fluid, colloid, and electrolyte replacement is the major focus of the medical management. The administration of several liters of an isotonic solutions is prescribed. The hypovolemia occurs because the massive amounts of fluid and electrolytes move from the intestinal lumen